Yeah, good afternoon. My name is Magda Eras. I'm a cardiologist from Barcelona, and my co-chair is Alexandros Sionis, also working in Barcelona. We are going to discuss three clinical cases. We have 30 minutes for each case, and we are going to do that with a very fine panel of specialists that are here with us. Bernard Gersh from Rochester, Minnesota, Dr. Margot Valgimigli, now in Rotterdam, Holland, and Robert Clouds in Leiden, he's the surgeon, and Dominica Angiolillo from Jacksonville, Florida. We thank all of you for being here, and Alessandro Sionis will introduce the case.
So we'll begin with Francisco Javier Rosselló, who will open with the first clinical case. It's titled A Mechanical Complication of Acute Myocardial Infarction. Francisco?
First of all, I'm very grateful to the chairman for inviting me to this meeting. I'm going to present a clinical case about an acute myocardial infarction. He was an 84-year-old man with two risk cardiac factor, hyperlipidemia and hypertension, and he took normally omeprazole because he had an hiatal hernia. He is a monk and he lives in a monastery. He does a normal life, and he has his activity daily living with no help. He does not smoke and drink, and neither use illicit drugs, as all suppose. And on 12th of February, he presented a new onset pain in the interscapular region, but he didn't call for help. The day after, he presented a new episode of chest pain, and he decided to seek help. This is the first ECG done by the ambulance assistants that showed a Q wave, established Q wave with ST segment elevation, suggesting all of subacute inferior myocardial infarction. For that reason, the patient was transferred from the monastery to the cath lab for primary PCI. This is the coronary angiography that shows, as you can see, a lesion in the mid-descendant arterial coronary. This is another view of the same artery, okay, and this is the view of the right coronary artery. And as you can see, we have a lesion in the distal portion of the right coronary artery and an occlusive lesion in the posterior descending artery, which was the culprit lesion. At the end of the procedure, we practice a ventriculography that shows an inferior wall motion abnormality. So to sum up, the coronary angiography showed lesions in mid-left anterior descending artery, in distal right coronary artery, and the culprit lesion was the distal occlusion in posterior descending artery. The revascularization was attempted, but it failed, and given that the patient was in a stable condition, he was transferred to the coronary care unit. So at that point, what will you do next?
Ischemia in this patient, or you should just transfer to the operating room or consult with the surgeon?
No, I would have done what you did, and that is you tried to revascularize, you couldn't. He's hemodynamically stable. And what is impressive is he has well-preserved ventricular function. He actually has hyperdynamic function, which you do worry about in an 84-year-old patient because that can predispose to rupture. But I would have transferred him on a beta blocker. I know we don't often, he's hemodynamically stable, and with that kind of ventricle, I would have transferred him to the unit, beta blocker and usual therapy. I would not have called a surgeon at this time.
Okay. Do any other options from the other panelists?
I think I would agree. I would not do anything else than what has been done. So of course the aim would be to reopen posterior descending artery, but if that is not going to be possible, to complete revascularization at that stage it probably does not make any sense to me. So to stop and start medical therapy and then reevaluate residual lesion makes a lot of sense from a clinical standpoint.
And I also would agree. It seemed like the infarct was quite under a certain number of hours of evolution. I think, but then the next question is, you do have a severe mid-LAD. The question is the timing. Definitely this is not the timing.
And Dr. Clouds, you have a surgeon. Would you have been happy to operate on this patient? No. Okay. But then we all agree.
Let's move on. The patient was admitted to the coronary care unit, and he arrived with a trend to tachycardia and hypotension. And in the first physical examination, he presented... I
guess I'd take back my comment about beta blockers. I wouldn't give him with a pressure of 87. I thought he was hemodynamically stable, pressure 120, but I wouldn't do it at 87.
I think he was stable, but this is the first physical examination in the ICCU. So during the transfer, something happened.
Oh, I see. Okay.
Okay, the first physical examination revealed a regular rhythm with whole systolic murmur at apex and clear auscultation of the lungs, with the rest of the physical examination in a normal way. In order to assess this murmur, we practice an echocardiography that shows here a ventricular septal defect. Here we have a subcostal 4-chamber view that shows the same apical defect in the septum. And
are you really sure that the neck veins were normal in this patient? Because I just don't believe that. The neck veins. I mean, acutely with a VSD, the right-sided pressures have to come.
Yes. Theoretically, is normal. Okay. In order to assess this, the hemodynamic compromise, we studied the QP over QS ratio that shows 4 times higher fluid of the pulmonary circulation over the systemic circulation with a normal ejection fraction. So to sum up the findings of the echocardiography, the position of the ventricular septal rupture was in the mid-inferior and mid-septal segments, and the magnitude of the left to right shunt was important because the size of the defect was about 30 millimeters, and because the hemodynamic compromise is proved by the QP over QR ratio. So at that point, what would be your next step in management?
Dr. Clouds, if you go and operate this patient right away, would you wait? What would you suggest?
Well, it's clear that the only mode of survival is an operation. And the question is the timing, and it's a very, very difficult issue. When you bring him to the operating room in shock, he will not survive. If you wait for 6 weeks, he won't survive that period. So he has to be stabilized until his renal function is normal and he's in stable conditions, and that probably will take you maybe 24 hours, 48 hours, and then we have to go to the OR. That will be my plan and my suggestion in the ICU.
So in practice, you will operate this man in 48 hours, if it's stabilized?
Well, I don't think you can he will survive a waiting period until the tissue is scarred, which will take weeks. He won't survive weeks with this VSR. So it's appealing to wait, but it's not a reality.
We did study these mechanical complications in detail, and as we looked at the early surgical literature, I agree with you. I mean, the strategy was to wait and stabilize, but what happened was you were just operating on survivors, and all the sicker patients died. So clearly, the operative mortality, if you wait, is lower. The conclusion we came to was if you operate on these patients earlier, the surgical mortality will be higher, but the patient mortality overall would be lower. And in our practice, we differentiate a little between papillary muscle rupture and a VSD. With papillary muscle rupture, I would not delay at all. I wouldn't wait 30 minutes if possible, because they may have a partial rupture, they will go on and they can get a complete rupture in front of your eyes. They also get pump lung and very severe pulmonary edema. With the VSDs, you may be able to wait a day or two. The problem is it's an inferior infarct, and those VSDs are complex VSDs, and they tend to go through, and they may also go through the free wall. So I think waiting 24, 48 hours, maybe, I would probably push to go earlier. If it is papillary muscle, I'd say go right now, but I think I'd still push to go earlier.
I fully agree with the papillary muscle. I would take the patient directly to the operating room. I'm just worried about his general condition. I'm not sure what was his creatinine and whether he's in a shock or not.
Do you have the creatinine?
So, what?
Can you tell me, yes,
renal function.
something more about his general conditions, about his lab results and,
yes.
and so on?
Okay. This is the first chest X-ray that reveals pulmonary edema, and this is the first lab results showing an increase levels of the cardiac biomarkers, and the rest of the blood tests are more or less normal.
So before you go on, so it looks like he's relatively preserved. It looks like he doesn't have severe kidney or liver or dysfunction, because his coagulation is all right, kidney looks all right. Is it stable enough for you to go to the first surgery?
I tell you, the creatinine will not be normal tomorrow.
No. Well, it depends. If you give him some inotropes, maybe a balloon pump and diuretics, he may be better tomorrow. I would definitely not do it overnight. I would want to do it in daytime. I think the chances of survival in daytime are a bit better than in the middle of the night. But
And the invasive cardiologist, do you have something to offer to this patient?
I agree with Dr. Gersh was saying. There's a lot of uncertainties with correct timing, but there's one thing that's certain: the patient at the current time is more or less stable. More or less stable. I would not wait any longer whatsoever, because an 84-year-old, we will not know how this patient will be the following day. And then there's the other component, which is dealing with our dear friends surgeons. As soon as the patient starts to go downhill, it always becomes an excuse not to send the patient to surgery. So that's the further reason why I say the patient's overall in good clinical condition, he's never going to be better, send the patient right away.
Whatever you do, you have to accept he has a very high operative mortality. I know that. We're, 30% range. I just don't see any advantages in delaying.
I fully agree with what has been said. I think the ideal scenario would be to probably insert the intra-aortic balloon pump in this patient. If the surgeon is willing to operate on him now, send it straight away to surgery. Because of course, the longer you wait, the lower chance of survival and the lower chance that the patient will undergo surgery. Of course, there are potential percutaneous options to close this VSD, but of course, these are second line. Only if surgeon declines surgery, that could be something to be considered. But these are bailout treatment with very little evidence of benefit, so I would really leave them as a second, third option.
Dr. Malcolm Bell?
I have to say that in these patients, we always find that, on paper it seems as though they should go to surgery. But this is the typical thing we see, a reluctance of the surgeon to take, it's 84. And I was also going to just raise the possibility of using a percutaneous approach with an amplatz or occluder, and we've actually done this in a number of patients. But it's actually driven more by the surgeons asking us to do this because they're not going to take the patient to surgery. So just a comment, and maybe there's going to be some more discussion about that. The other comment to make, though, in these patients, I think it's important to make sure you know what the right ventricular function is too, because I think as a surgeon, if the right ventricle is, really severely dysfunctional, this becomes, incredibly high risk, and this has been something that's been taught to me by our surgeons, that if the right ventricle is really shot, this patient's not going to do well, it's probably not going to come off bypass.
Yeah, the trouble in assessing this RV function is that it's going to be volume overloaded anyhow. So it may not contract very well just because of the volume overload. It doesn't need to be ischemia. The problem, his ischemia is really distal in his right, so my estimate will be that his RV is good enough to survive the operation, my estimate.
I think the problem with a percutaneous device is there's a difference between VSDs that occur with inferior infarcts and those that occur with anterior infarcts. With anterior infarcts, and it's interesting to look at the autopsy, the pathology data, with anterior infarcts, they're what we call simple VSDs, through and through, clear cut. With inferior infarcts, they're much worse. They're complex VSDs, much more ragged. Often you have two VSDs. You also have, often involves, the RV is infarcted as well. And those ones can often go through the free wall. So I don't see a percutaneous device doing very well in this situation. Maybe with the anterior, maybe.
I think it depends a little bit whether it's phase or more out. This one looked a little bit more out.
But what drives me here is he had a small infarct. We saw that ventricle, and that's probably why he ruptured, is because they are small infarcts. They have to have the shear stress to rupture. So I would still keep pushing to get this guy in, but I realize it's a very high mortality.
Yeah, something I forgot to mention before. Apart from intraortic balloon pump, what I would really consider here is immediately starting non-invasive ventilation with possibly high PEEP value, so that you can increase intrathoracic pressure and you tend to unload the right ventricle. That would be very important to stabilize the patient before surgery. And again, I insist, as an interventional cardiologist, surgery is the only way this patient can survive, in my mind.
Okay, let's move on.
Okay. Well, we thought that he has three options. First one, do nothing. Second one, do a surgical closure. And the third one, do a percutaneous closure. So after discussing with the whole heart team, the surgeons rejected the surgical closure. And then we use a CT scan in order to study the nature of the defect. So, as you can see, the septal defect is in the mid-apical segments, and the size of the defect was 24 per 30 millimeters. So, because the patient was increasingly worsening, finally we decided to close the defect via percutaneous. So the 12th of February, 1 week before his admission, the patient was intubated and an intra-aortic balloon pump was inserted, and
Sorry, Javier. Just one thing. So I understand that you still waited 1 week to see whether the patient was stable enough to go to surgery, but since he was unstable, in the end, you decided to do a percutaneous procedure.
Yes.
Is that right? Okay.
Okay. So this is the intraprocedural transesophageal echocardiography that confirms the defect. Here we can see the wire crossing the septal defect, and here we can see the delivering of the device, which was placed in the correct place, as we can see in the post-interprocedure transesophageal echocardiography that shows a reduction of the shunt. This is the control CT scan that shows the device in the septal defect, and the two.
Can I ask you a question? So you use a transseptal approach and then from the left to the right.
Yes.
Is that correct? Okay.
Okay. The summarize of the procedure. We delivered the device, the largest one, and the post-procedure QP over QS ratio was 2:1. Well, the clinical course in the coronary care unit was positive. We removed the intra-aortic balloon pump in less than 24 hours. We extubated the patient in less than 48 hours. But in spite of this positive clinical course, the QP over QS ratio was increasingly higher. So at that point, we decided to withdraw the antiplatelet anticoagulation therapy in order to promote the epithelialization. The 3 weeks after his admission, the patient moved to the ward with good tolerance to the beta blockers and oral vasodilators. He was independent for his personal care, and the control echocardiogram finally showed a QP over QA ratio of 2:1 and an estimated pulmonary systolic pressure of 30. The medical treatment at discharge was enalapril, beta blocker, aspirin, and omeprazole. And finally, 5 weeks after his admission, the patient came back to his monastery. At follow-up, the echo shows a persisting left to right shunt. He is clinically stable without symptoms or signs of heart failure, and he has a good quality of life because he says that he can climb the stairs of his monastery.
Any comments from the invasive cardiologists, ways to approach that, why it worked?
Well, it's a fantastic case because he succeeded basically in saving the life of the patient, but unfortunately I have a different experience. I have done personally 3 of this procedure and all 3 of my patients died, so I don't see that much of an indication to this procedure unless, as in this case, the surgeon really declines the patient. And I think we should, as interventional cardiology, push our friends, surgeons, to operate on this patient a little bit earlier than what they do. And the reason why I'm saying this is because I had the privilege to be part of this ESC Revasc guideline committee, and this specific topic had been discussed for hours. And actually, even within the surgical community, there are a lot of differences between the portion of the surgeon willing to operate as soon as possible because they know that otherwise the patient will never survive, and of course the conservative quote-unquote surgeons who would like to wait to see if and when the patient stabilizes, which is probably a dream. So I think this is a successful case, but I think should not deviate the attention towards the fact that probably the best treatment in this patient is surgery in my mind.
And I have one comment as well. You removed the anticoagulant and the antiplatelet, although I don't know which one they were, with the idea of promoting endothelialization. I think that 2.9 value, which could have been a fluke, because I think in 3 weeks to get back to 2.0. Yes. And you also risked it because the patient had an ACS, so you removed everything. And so I think you were lucky that there was not a recurrent ACS But it was a very good case.
When did you restart aspirin?
At the last week of his clinical admission.
So the patient was almost 3 weeks without any antiplatelet or anticoagulant. Any other comments from the...
Well, it also shows that the patient did survive without any therapy for a couple of days. So I think there still is a window to get the patient to become not in terms of his heart, but in terms of his entire body, a surgical candidate.
Well, when we looked at our series, one of the features that struck us amongst the patients that were operated on was, although many of them had small infarcts and the mechanical defect was corrected, the post-operative course was extremely, extremely prolonged and stormy. They needed an average, if I remember, it was 12 days of ventilation. And part of that is, I think, particularly with the papillary muscles, but maybe also with the VSDs, these tremendously high filling pressures give them a form of adult respiratory distress syndrome, pump lung. And I think, again, I'll go back to what we concluded in our JAMA paper, and that was early surgery will increase the surgical mortality. The surgeon won't look as good, but it'll reduce overall patient mortality. And it's very rare that I can make a case for delaying. I think it's a great case, and you did well. But, you know, there's the patient actually declared himself by surviving without therapy for a few days, you know. It's like that drug. Everybody I give the drug to gets better except those who died, but they were going to die anyway.
Bernard, I fully agree that we have to look for lower patient mortality and not surgical mortality. But saying that, the problem is that I think this type of pathology is not very common and less common. And the problem is in the hospital you may have 5, 6 surgeons there, and may they do one case every year. So there is no expert. You don't have anybody who is the expert on VSDs at 3 o'clock in the morning. And for those who have been doing some cases, they realize that it's like butter. And this case maybe was good because it was a small myocardial infarction, as you mentioned. But when you have a larger one, it's really butter. And technically speaking, it's really tough to do. And that's why I personally feel today, after years of surgery, that if you were able to get something to do it percutaneously, although I understand what Marco said about, probably it would be better for the patients at the end. Extracorporeal circulation is not good for those patients neither, and they have a recovery which is tough, even sometimes tougher than the surgery itself.
Thank you.
Okay, thank you very much. If there are no other questions, we call on Alba Santos from Barcelona for the second case.
Good afternoon. It's a great pleasure for me to be here. I'm presenting a clinical case which tries to illustrate that in medicine things are not always what that they appear to be. Our patient is a 63-year-old man, obese, with several cardiovascular risk factors such as arterial hypertension and hypercholesterolemia under medical treatment, and a past smoking habit. He has had a traffic accident in 1991, resulting in cranial trauma and epilepsy, which requires medical treatment. Besides, he was awaiting a surgery due to a perineal abscess. And till this moment, he has not had any previous cardiac disease. He presented with a sudden onset oppressive chest pain, no exercise related, irradiated to the left arm and accompanied by profuse sweating. He called an ambulance and he was transferred to the emergency department of our hospital, where he arrived 2 hours and a half later with persistent chest pain, a normal blood pressure, and 75 beats per minute. The admission electrocardiogram, as we can see on the slide, show an ST segment elevation on the inferior leads 2, 3, and AVF, as well as a ST segment elevation on the anterior leads from V1 to V4. Considering these findings, we wonder that what could be the most likely culprit artery in this case? An acute occlusion of a very long left anterior descending artery which surrounds the cardiac apex that can explain the ST segment elevation on the inferior leads? Or an acute occlusion of the proximal third of the right coronary artery with right ventricle involvement which can justify the ST segment elevation on the anterior leads?
Any guesses on this one?
The honest answer is I really don't know. If I had to bet, I'd bet on number 2, but I don't know. Those ST segments, though, in the anterior leads look funny. They're unusual. I think here I'd really, I'll tell you what I think it is after I've seen the angiogram.
I would go for number 2 because it's really V1, V2, V3, not V4, V5, and V6 as assigned elevation. So that speaks more for a occlusion of a right acute branch of the right ventricle more than LAD. That would be my guess. But of course, in 1 second you do angiogram and you find out.
And if I
could also explain the strange pattern in V1, V2. It's very strange ST elevation.
And I would vote for number 2 as well, for the same reasons.
So yes, as the specialist has already said, and regarding to some observational studies and their conclusions, if there is a progression of the ST segment elevation from V1 to V3, we will consider the left anterior descending artery as the first option. But in this case, with a ST segment elevation that is almost the same in V1 than V3, the right coronary artery will be our first choice. So considering that...
Just a second. Do you agree, Bernard, with this?
Yeah.
Okay.
So, as expected, we perform an emergent cardiac catheterization, and following the normal clinical practice in our hospital, we first try to visualize the artery that we didn't expect to be the culprit one. So we catheterized the long anterior descending artery, and surprisingly, as we can see on the angiogram, we found a proximal third occlusion, acute occlusion of this artery. And on the video on the right, we can observe that there was a high content of thrombus when we opened the artery. The patient was pre-treated with a low doses of clopidogrel, 600 milligrams, as well as 300 milligrams aspirin, and we added a total of 10,000 international units of unfractionated heparin. A primary percutaneous coronary intervention was conducted at this level. We did a mechanical thrombectomy, which was effective. We administered intracoronary apiximab, and finally we implanted a bare metal stent at this level. Nevertheless, the patient persisted with ST segment elevation, intense chest pain, and and we can find the answer to these symptoms in the angiogram. The green signal shows that there are some collaterals from the long anterior descending artery going to the right coronary artery. So we catheterized the right coronary artery, and we found an acute occlusion in the middle third of this artery. We opened the artery, finding a high content of thrombus, and a percutaneous coronary intervention was performed in this middle third of the right coronary artery with mechanical thrombectomy that was also effective, and the implantation of a bare metal stent. At the end of the procedure, the patient was asymptomatic. So under this scenario, my question is, should we look at the angiogram of all the coronaries before making a decision about the intervention?
Any comments?
So I will start off. The answer is yes. You want to have a clear understanding of the coronary anatomy, also because it just takes no more than 2 minutes to squirt all the coronaries. But ultimately, in this case, I think you did the right thing, because the only different thing I would have take a picture of the right coronary artery and then approach the LAD and then evaluate clinical evolution, because with those well-developed collaterals, you'll never know if what you're seeing on the right side is acute or chronic. But definitely take pictures of all arteries first.
Could I ask you something? If you'd shot all three, you would have gone for the right. And then if you got rid of the pain, what would you have done? Staged the left? Because I think the right was the culprit.
Yeah, I fully agree. I think I would have first visualize all three vessels, first reopen RCA, and probably even if the pain was disappearing, I would probably have treated LAD anyhow, because it was a limited flow baseline. So it was a TME1 flow. Otherwise, I would have left it as it is and maybe staged later on. But I still believe that RCA was the culprit lesion here, and not LAD.
Dominic?
Yes, I think one of the questions was quite interesting that you used bare metal stents.
Sorry?
You used bare metal stents and not drug-eluting stents, particularly considering, I know it's not the fellow's fault, it's the attending fault. But if you think about in STEMI, they're very good data with drug-eluting stents, and then you had a prox LAD.
Yeah. I think there was something in the previous medical history that probably prompted to choose a bare metal stent over a drug-eluting stent, or?
Yes, there was a doubt about the history about the traffic accident with cranial trauma, and we were not very sure if there was an hemorrhagic, cranial hemorrhagic. So maybe the decisions were influenced by this antecedent.
Yeah, to follow up, if I can, to follow up on this comment, I think the best of evidence suggesting that ADES should be implanted in this patient is coming from Spain with the examination study. Not just because you are sparing TVR, but because there is a reduction in stent thrombosis rate. So this BRMS should be probably abandoned in my mind.
Maybe the economics also play a role in this case. We don't know. Bernard, what would you do after that? What kind of antiplatelet therapy would you put the patient on?
He is not on warfarin for any reason, right? Well, I think we're looking at really the most controversial area in cardiology, and the question you should ask me, Magda, is what form of dual antiplatelet therapy am I going to do now, and what will I be doing in 6 months' time, and what will I be doing in 12 months' time? And I don't know. With the bare metal stent and acute coronary syndrome, he'd go home on aspirin and one of the new antiplatelets. And our guidelines still say it's acute coronary syndrome, 12 months, but I think that's going to change.
Okay, Marco, please.
It's difficult to give a short answer to this. I think it's a huge topic, and I think guidelines are going to change because the evidence supporting this 12-month period is basically nothing. So, and we have today 15,000 patients randomized, which are to some extent questioning this 12 months, which is completely arbitrary. So I don't know whether it will be longer or shorter. That's difficult to say, but this 12 months does not make any sense to me. Also because it does not come from anything. Even the CURE study, the median duration of the APT was 9 months.
Right, and the 12 months was an FDA decision. I think the truest answer that I've heard is whatever we do now, it's going to be different in a year's time, I think.
What What about, Dominique, the second antiplatelet? Because we assume that the patient was on aspirin. Which one would you give?
Definitely, I would give one of the new agents, and obviously the question is, ticagrelor or prasugrel. I typically, in STEMI, as part of our protocol, we're using more prasugrel. But this, I think, is a good case for ticagrelor because of the prior head trauma. Not much is known about what's going up here, so you're in the setting of a STEMI. So when you don't know, probably go with ticagrelor. But again, either agent is an option. I think this patient should not go with clopidogrel, that's for sure. I think the other question is, how the patient was managed in the cath lab at the time of STEMI. Here they decided to use intracoronary 2B3A. It would be nice to know if it was just an intracoronary bolus or infusion.
Can you answer that, please?
Intracoronary infusion, I believe.
So 12-hour infusion.
I'm sorry?
With 12-hour infusion or bolus only?
No, I think intracoronary bolus then.
So bolus only.
During the catheterization.
And this on the background of unfractionated heparin?
I'm sorry?
On the background of unfractionated heparin?
Yes.
Not bivalirudin?
And with unfractionated heparin, yes.
Because, for example, our center by default, and now there's a lot of debate, but as soon as the STEMI patient hits the cath lab, we start the bivalirudin. This was definitely a good case for
was that before the ACC meeting or after the ACC meeting?
It was before, and I've had a few STEMI cases afterwards, and I think that the heat primary PCI data really need to be better digested. I believe that there's a lot of solid data with bival in primary PCI.
Well, there's a lot of solid data with bival in primary PCI versus heparin and a 2B3A. There's not so much data with bival, but just versus unfractionated heparin. I think that's what came out at the ACC and caused all the shouting match that we saw. Yeah, so it's up in the air as far as I'm concerned.
So my opinion, definitely data that need to be digested. One thing that has not been fully discussed about the trial is potential for underdosing of bivalirudin, because ACT levels around 50 units lower. There was never any dose adjustment, while in the heparin arm, there was. So I think very important clinical trial data. I have not yet changed my practice.
Yeah, and also what was a little bit strange to see is that everything was in disfavor of bivalirudin, not just acute stent thrombosis, which is basically the leitmotif that we see everywhere from Horizon as well as Euromax. Mortality was numerically disfavoring bivalirudin. Stroke rate, if you look at the numbers, were twice as high in patients having received bivalirudin. So I agree with Dominique. This is an important study, but probably we need time to digest the data, and most likely to see the paper published would also help.
I'll just say one aspect about Horizons, because I was involved with that I was chair of the DSMB, and Dr. Pocock may have more to say on this, but we saw a mortality difference very early on, and it's okay to talk about this now because the trial's been published and everything. But what it was, and the reason we never stopped the trial, it was a very high mortality in the heparin group, surprisingly high, and a very surprisingly low mortality in the bivalirudin group. So it was unlucky, I think, for heparin. So that's why we didn't actually stop the trial. We continued. In the end, that mortality difference, I think, became 0.057. And then when you went out to, I think our Lancet paper was at 2 years, I think, 3-year mortality. It was significant, but as Dr. Pocock pointed out, actually, if you just took 2 or 3 deaths from one arm and put them in the other arm, it fell away. So I think the mortality benefit was, sometimes things happen in trials, and I think it was higher than expected with heparin. So I think the bivalirudin, we're going to need another trial with adequate dosing, because I think your point's a valid one.
Well, I'm happy to let you know that we are running the Matrix study. This is going to be 9,000 patients, and we are going to randomize bivalirudin versus UFH plus provisional GPI, not systematic GPI, because this does not reflect current practice anymore. So I think that study will be very informative.
So it's going to be bivalirudin versus
UFH plus GPI at discretion of the physician.
Yeah.
And right now we have a proportion of 25-30% use of GPI. So it's not 80% like Euromax, nor 100% like Horizon Semi.
Can't wait. I mean, that's really an important trial.
Okay, go on, please.
Perfect. So immediately after the procedure, the patient was admitted to the cardiac intensive care unit. He arrived asymptomatic, with normal blood pressure and without heart failure signs. The first analysis showed normal values except from a high elevation of cardiac necrosis biomarkers, up to 100 times the normal value. As usual, we started the secondary prevention treatment during his stay at the unit, and he saw a good tolerance. The electrocardiogram after the catheterization showed the appearance of Q waves on the inferior leads, as well as Q waves on the anterior leads. And again, my question is that, would you think that the greater sum of ST segment elevation and the greater number of leads with ST segment elevation are always related to a worse left ventricular function?
It is certainly related to an adverse prognosis. We've looked at this and studied it. I don't know that we can say that it's probably due to poorer LV function, but it is certainly a reflection of microvascular dysfunction and reperfusion injury, if I can use the term. And it is certainly prognostically relevant. The data are out there, but I don't know exactly what the correlation is with, say, ejection fraction, but certainly with prognosis. And the other factor is the presence of Q waves.
Yeah, I agree. I think there is sound evidence showing that the answer is yes with respect to mortality. I don't think I can answer the question with respect to ventricular function because I don't know the data. Also, another point for consideration is when are you considering the ST segment elevation after the procedure? Because what we have seen in 2 or 3 studies is that the earlier you do that assessment after PCI, the better it is. And the more you wait, the less prognostic information you still have in that variable.
And I agree. It's definitely a strong prognostic marker. And although ultimately in everyday clinical practice we'll just get an echo and have an answer, but this is clearly a patient that you're going to want to follow closely, and it'd be a patient that, now I don't know what the EF here is at discharge, but reevaluate at 40 days.
Okay. So as usual, an echocardiogram was performed during the first days in the coronary unit. In the video on the left, the fourth chamber axis, we can observe an anteroseptal akinesia. And on the views on the right, we can appreciate an inferior and inferioseptal akinesia. Instead, we observe a left ventricular function that was almost normal, 50% ejection fraction, and there was no pericardial effusion. 4 days after the myocardial infarction, a cardiac MRI was performed. In the picture on the left, we can observe a 4-chamber axis with late gadolinium enhancement study that show an subendocardial catchment suggestive of subendocardial necrosis in the anterior septal side. In the picture on the right, we observe catchment through all the myocardium, suggesting inferior and inferioseptal transmural necrosis. We could also notice microvascular obstruction without hemorrhagic transformation in the inferior and inferioseptal sides, pointing to the transmural necrosis in this territory. And on the pre-contrast sequence in the picture on the left, we observe signs of myocardial edema in both territories, which confirm that there was an acute occlusion of both arteries. To conclude, I would like to know the opinion of the specialist about the management and the treatment of this patient. Is he different from any other STEMI patient with respect to the etiology? The diagnostic test, in example, should we perform an hypercoagulability test in this patient? And the therapy, what should be the treatment during the acute phase and the follow-up?
How often do you see dual coronary vessel obstruction for acute thrombus? Is it frequent? Is it rare?
This is definitely a rare presentation, but having, as we all know, multiple plaque rupture in the setting of an ACS is quite common. And so with regards to the etiology, we know that this is a systemic disease, and I wouldn't give it more thoughts. I just think that this patient had multiple plaque rupture, and that's it. I would not do any type of hypercoagulability assessment. I think the most important thing for this patient is being very aggressive with the medical management in the acute and follow-up phase.
Can you tell us on what medications the patient was discharged?
Yes, he was discharged 4 months ago, and he's treated with clopidogrel and aspirin that will be maintained for 6 months, and well, normal treatment with beta blockers, enalapril, and statins.
Thank you.
So my comment is that the fact that you see thrombus in a lesion which you don't think being the carpet lesion at the moment of STEMI does not speak for the fact that you have two carpet lesions at the same time, because actually it is very well described in the literature that the pan-coronary syndrome does exist, and it has been reported back in 1999, I guess, from Goldstein in a fantastic New England paper, describing the occurrence as well as letting us know that, of course, the prognosis of this patient is much worse than patient which you have only one suspected culprit. And the reason why I'm making this comment is because I'm still not sure that LAD was also contributing as a culprit. I think the fact that you have seen edema at MRI could be justified by the fact you have induced a peri-procedure MI during intervention itself. And that is exactly the reason why, as an interventional cardiology, I want to see very solid data before deciding to go ahead and do complete revascularization in the setting of STEMI, because my really concern is that I will, of course, fix the carpet lesion, but if I have whatever complication in artery which is not the carpet lesion, this patient will have two MI at the same time. And probably that could be something which has happened here as well.
I have really nothing to add. I agree with everything that you said. To go back to your original question, and that is, does the lack of ST resolution correlate with poorer LV function? And as I think we all said, we know it correlates with mortality, but not with LV function. But you know, we did look in the Cadillac trial where there was a 2% mortality overall. If they had lack of ST resolution and no myocardial blush grade, which is another parameter of microvascular function, reperfusion injury, the mortality at 1 year was 10%. 10% in a low-risk group of people. So what I would be concerned about here is that 40-day, I think, Marco, one of you mentioned, the 40-day follow-up. I'm surprised the EF is 50%. I thought it was lower than that. But it may be that when the the hyperdynamic features settle down, that you'll be dealing with an EF of 35–40% with 2 infarcts at 40 days. So I would be very concerned about assessing this patient for a defibrillator, and I'd probably put in, as an added drug at this stage, an aldosterone antagonist. But I think the 40-day follow-up is really going to be important.
Robert, do you have anything to add to our discussion?
No, the treatment of acute myocardial infarction is not in the operating room.
Not surgical anymore.
No.
Anymore.
Any questions from the audience? Any suggestions?
Well,
okay.
We move
Thank
on
you.
to our last case. Thanks a lot. And so we have a bit of a technical issue here with the videos, because it's a case with lots of videos, I understand, so they have to switch the computer. And Nuria Ferrer from Tarragona, Spain, is going to present our next case.
Good case. Just wait for now.
Have you ever seen anything like that? 2 lesions?
Yeah.
Do you believe there were 2 lesions at that time?
I don't think, I'm not sure there were 2 culprit.
Determined to invite me here today to discuss this difficult case, so let's start. Our patient was a 57-year-old woman. She lives alone and she has no close family, but she had an active life, walked every day, and she had no known allergies. She was quite a heavy smoker of 20-30 cigarettes a day until she quit 3 years ago, and she had hypertension and dyslipidemia, but no diabetes. She also had chronic kidney disease, and her first admission was in 2010 that she went to the ICU due to abdominal septic shock. At that moment, she required hemofiltration, but her renal function recovered enough that she was discharged out of renal replacement. And her history with us started on May 2012. She was on the renal clinic discussing permanent access to dialysis when she had a sudden onset of shortness of breath. She was hypotensive and she had to be intubated. The ECG at that moment showed no ischemic changes, and they made a CT that ruled out pulmonary embolism, and then she made an echo that showed an anterior akinesia with ejection fraction of around 40%. So she was intubated, she needed inotropic support, she was put on the hemofilter, and she had 2 main complications. One was a ventilator-associated pneumonia caused by a methicillin-resistant Staph aureus, and then she had a worsening anemia and had to be transfused. And we did an angio that showed, as you will see here, left main and proximal and mid-LAD disease and circumflex disease. So, and the right coronary artery had only a 50% lesion, as you can see here. So we calculate your score at that moment. That was around 12% of mortality. Syntax score was 31, and we also have to take into account that she had anemia, she had pneumonia, and some degree of ICU myopathy. So what would you do in this case? Would you just try to stabilize her, extubate, and then go for CABG maybe in second admission, go for PCI directly, or go for medical management?
Dr. Clouds, please.
Her coronary problem is now stable. She's not having any problems. So there is time to wait. I don't think there is a hurry. The time that we operated on main stem stenosis the same week is a little bit behind us. So you will have some time to wait, and I guess in general a bypass surgery would be probably most likely my advice. Yeah, we'll discuss it in the heart team obviously, but the main stem, proximal, LAD and circumflex, yeah, I think so.
Bernard?
Yeah, I think that you say she's hemodynamically stable.
Well, she needed inotropes at the time that we first discussed her with the surgeons, and then she had the pneumonia, so she needed more noradrenaline. So she was somewhat improving, but she was in shock.
But she's not in shock.
She was in shock at the time we discussed her, and then she.
But she's not now.
No.
I think she's got 2 things you can treat. You can treat anemia and you can treat pneumonia. And I would continue with medical management, but with a view to cardiac surgery once that's cleared up.
Marco and Dominic?
Yeah, I would like to know whether you can let us know the amount of CKD. I mean, what was the residual creatinine clearance in this lady? Maybe you showed the information, I missed it. If so, I apologize, but I don't remember the creatinine clearance.
Well, she had a filtration rate of 15 at the moment, but she was immediately put on the filter because she was being assessed for dialysis as an outpatient in the outpatient clinic, and when he was admitted, she was anuric, and then we put her on the filter. So it really doesn't matter much because he was on dialysis.
So of course the easy answer would be we discuss the case in the heart team and that's it. The difficulty of this case is that unfortunately we lack randomized controlled data in this specific setting. In the CKD, we have no specific randomized data. And if you look at registries, propensity match, whatever they do, they would suggest that long-term survival is better after CABG than PCI. But on the other side, this patient has quite an amount of comorbidity, which would push for PCI. And anatomically speaking, PCI does not seem to be that difficult procedure, to be honest. So I think there is still room for both PCI and CABG in this specific case.
And would you do PCI right away?
No, there is no need to rush for PCI straight away. I think that it can be discussed and can be done later on. There is no need to do it emergently.
One question I have, and then you may have presented it. What's the ejection fraction?
Oh, yeah. At first, it was around 35 or 40%. It was not severely depressed.
Okay. So I agree with Marco. I mean, this is a case that if the patient has been stabilized, try for medical management. The big question is, how long will this patient need to be in the hospital? Or is there risk for further complications down the road? Definitely needs to be discussed with a heart team, but from a technical standpoint, it's not that difficult of a PCI.
Okay. So we discussed her with the cardiac surgeon, and it was agreed that we should continue with medical management or PCI depending on the evolution. And she was extubated and transferred to the cardiology ward, but the next day she had acute pulmonary edema, was reintubated and admitted to the CCU. The echo showed the same. And at that point, we made a PCI with drug-eluting stent in left main LAD and mid-left anterior descending. You can see here the results in the mid-LAD and the left main. So it was a good result. She was discharged on full medical medication, aspirin, clopidogrel, bisoprolol, atorvastatin, enalapril, and many other medications. And she was well until this year when she was admitted 4 times. So the first time was some 11 months after this first admission. She came with an anterior lateral STEMI complicated with cardiogenic shock again. So she was intubated, she had an intra-aortic balloon pump inserted, and she needed inotropes. And as you can see here, she had a left main restenosis and LAD intrastent occlusion, so we did a primary PCI with a drug-eluting stent in the mid-LAD and angioplasty with a drug-eluting balloon in left main LAD, and then another drug-eluting stent in the circumflex. So she was discharged home, and about
just a second.
So I want to go back to the prior procedure. You had a complex case.
Yeah.
Did you do an IVUS to make sure? I'm speaking the first procedure.
The first.
Yes. Was an IVUS ever performed to ensure adequate stent apposition?
Yeah, with routinely IVUS when we put a stent in the left main. It's standard practice in our hospital.
And it was a bifurcation stent technique, I guess, but which one?
I'm not sure. Well, should I move on?
Well, can I comment on the high risk of a patient? The Euroscore was designed to compare groups of patients, and it's never been designed to assess an individual risk of a patient. So I don't think it's fair to use the Euroscore to say, well, this patient is at high risk. You have to individualize and see what you can do for that patient. And in the situation in intensive care unit with a pneumonia, that's obviously not an ideal situation to bring a patient to the operating room. But if she will be stable, the fact that she has a bad kidney is gonna reduce her life expectancy, but not necessarily make it more difficult for surgery or PCI. So the fact that she has this risk should not be an argument not to operate this patient.
Well, I agree. I mean, the risk was given basically because she was unstable at the moment. But if you calculate the score in a stable situation with only the dialysis, the risk was not that high.
And even if the patient is unstable, still I would consider a surgery. It's only when she has ICU problems like pneumonia or that I would really focus my cardiology colleagues to take her to the cath lab. But otherwise, I think the surgery would be definitely the way to go.
Just to echo what Dominica said before, I mean, specifically in this patient population, left main plus CKD, you would like to see some IVOs to make sure that you have a proper expansion of the stent, because sometimes you don't see calcium in this patient, but you do have a calcium, and the stent simply do not get bigger unless you want them to get there. So I think for both reasons, IVOs imaging at the end would have been very important. And what sort of P212 inhibitor was she discharged with? Clopidogrel. That's another probably reason.
Yeah,
for
we will discuss it later on, but she's a patient with chronic kidney disease, so, well, we can discuss it later because you'll see that she had more complications. So this is the second admission that year, 4 months later than the first that we have seen. She came with a pre-respiratory arrest due to acute pulmonary edema, again with ST elevation V1, V2. She also had a balloon pump, she needed noradrenaline, and here you can see they show. Again, a restenosis of the lane main stent, proximal and mid LAD, and proximal circumflex. And she had an IVUS guided, again, with a drug-eluting stent in both left main, LAD, and circumflex.
So one of the questions, and I agree with Mark, after the first procedure, complex, even though there are no data in patients on hemodialysis, this patient needs to go on one of the newer agents. But if for whatever reason the patient doesn't and comes in with another event, the patient was lucky to survive the first time. Yeah. The patient needs to go home on a newer, and I don't know if you switched at that point.
We'll come to this now. Yeah. So she was transferred to the ward. She had a new pulmonary edema. She was reintubated. She had a new angio that showed no changes with the previous one done 1 week before. And she was extubated in 72 hours, but she had laryngeal stridor. She was reintubated and had a tracheostomy. And finally, she was decannulated 9 days later. Surprisingly, the ejection fraction was around 50%. And this is the second admission of MI due to stent restenosis, as you said, what we can do. So we can switch her to prasugrel or ticagrelor, although very few patients on dialysis are included in the randomized control trial, and the EMA do not recommend them in patients in dialysis. Should we have done a platelet reactivity test? We don't have them in our hospital, but we could have sent it to any other centers. Would you have operated on the patients? What do you think is the best?
Dominique, can you tackle the first one, please?
So the first one, definitely I would have changed. I think I would consider ticagrelor in this case only because she was anemic, and for whatever reason, the offset of ticagrelor is a little bit faster, and it's still a contraindication. I understand that both the FDA and the European Medical Agency say no, but that's where your clinical judgment prevails and overcomes any type of guideline or clinical trial. So with regards to the first point, the animal studies and restenosis, I really don't believe too much in that. That's for the first one.
What about surgery now? I know the angiogram was normal, but this seems like something is going to happen very soon. Or,
the two problems. The first is that all patients that have had prior PCI do worse than if they had no prior PCI. So once you go on a pathway of PCI in this type of case, your added benefit of surgery becomes less. So that's number one. And number two, to put bypass grafts on open coronaries is it's not something I've done before, and probably the fate of the graft is going to be pretty bad. If it's a venous graft, it will close, probably before you reach the ICU. If it's an arterial graft, it may do something.
Well, I've often asked our surgeons, because we often have the situation, someone comes in with an anterior infarct, they go to the cath lab early hours of the morning, they have an occluded LAD which is stented. And now you're left with disease in the other two vessels. And I've often asked our surgeons, have you ever been tempted to crimp that LAD? Because, I mean, the fact remains, if you put even a lemur into widely patent LAD, there's about an 8% risk of the string sign with the left internal mammary. So you're really stuck. And what our surgeons have said, they've been very tempted, but they've never done it. But it's a difficult situation because, I don't know, what is the risk of internal mammary staying open into a widely patent LAD?
What I do not know, but there are reports that even string sized limas open up after the native vessel gets stenosed again. So it's a live vessel and it can adapt its flow to the needs. So it can reopen again. So
I don't think you can operate in this patient with open arteries, not no. At this stage. No.
Okay. What about platelet reactivity tests, Dominique?
The answer is no, because we already have an answer.
Okay.
I have a more difficult question. If you would ask me to operate the patient when it comes in with an MI and stenosed stents, then what you do? You have so much quicker reperfusion with a percutaneous approach that it's.
Have you done any emergent surgery for acute MI lately?
It's a few times a year, but it's rare.
I think that I'm not so sure that this MI was driven by restenosis. I mean, probably it was a combination of restenosis and thrombosis, first comment. Second comment is, once you decide to go ahead in that specific setting and start implanting again multiple stenting, I think you have already taken the decision. If you want to send the patient to surgery, you can simply establish a T-metry flow with balloon angioplasty. And then day 2, day 3, the patient can undergo surgery. So I think the decision about the manager has already been taken during the index PCI here.
Okay, let's go.
Okay, so we decided to continue with aspirin and clopidogrel and repeat the angio in 3-2 months to see how the stents were. But unfortunately, before we did that, he was admitted again on January of this year with an anterior STEMI, Kilip 2. She was not intubated this time. And here you can see that she had proximal left main restenosis again, and a restenosis and TME flow grade 1 to 2 that was considered the culprit in the LAD, and a circumflex restenosis. And our interventional cardiologist did an IBUS-guided PTCA in left main and LAD, and circumflex was not treated because the patient was stable, so we stopped here. But now she complicated with a ventricular fibrillation just after admission in the CCU, and then she had a confirmed retroperitoneal hematoma that was managed with red blood cell transfusion. We usually use the radial approach always as a default, but in this case she had a fistula in the left arm, and we knew from previous angios that the right radial was not suitable for treatment, so we went to the femoral, and she had the hematoma. So she was discharged on 31st of January with a planned follow-up visit in 2 weeks to discuss the possibility of surgery of the circumflex and LAD. But the very same day that she was supposed to go to the clinic, she was admitted again with a non-STEMI, bradycardia, hypotension, and she was intubated again and given noradrenaline again. But she had a very good course and was extubated in 24 hours. And the angio at that moment...
Just a second, yeah. Dr. Dominique.
Yes, you gave the 3 options, which was switching drugs, platelet reactivity, or surgery. I would have added a 4th option, which is calling the first patient the monk.
Yeah. So this is the angio when she came, and the final angio. So here we were quite, we didn't know what else to do. So you can see here she was admitted on May, first admission, and then restenosis, 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 restenosis. So we finally decided to discuss her again with the surgeons for CABG. On the pre-op evaluation, we saw a very severe respiratory defect. That is surprising because we never had any problem ventilating or extubating her. And the supraortic ultrasound showed severe bilateral atheromatosis, but not critical. And finally, the cardiac surgeons agreed to operate her on, and it was done last month. They put a Lima to distal LAD and right interior mammary artery to the right coronary artery, and the circumflex was not treated because it was of very small diameter. And they planned to go off pump because she had a porcelain aorta, but she had ischemia with hypotension during the surgery. They had to go on pump. But she was fine. She was extubated in 6 hours. She had an eventful hospitalization. The echo discharge showed an apical akinesia with normal left and right ventricular function, and she was discharged and has been fine this less than 2 months. So I hope she keeps the same.
Wow.
Dr. Clouds, do you think that they waited too much to take the patient to the cath lab, to the operating room?
Yeah, I do. I really think that at the initial situation, I would really push for a bypass surgery. And I think, I mean, PCI is just a wonderful technology that brings so much to the whole cardiac community. And it also made my nights much better than the day before PCI. But still, these are although it's technically possible, you can see how things evolve. And in the end, the lady is only 50-something. You have to look in the future, 10, 15, 20 years ahead. And then it becomes a little bit different.
Bernard, what would have been your approach?
No, I agree. I agree. I think I thought only cats had 9 lives, but she has many lives. She's very fortunate. I would have pushed for surgery earlier.
What do you think about her prognosis in the long term? Because I know she's been operated on, but no, I think it's only 1 month after surgery.
I think it's questionable. You know, she has grafts to patent arteries. I accept that if the artery closes down, the graft can open up, but those grafts are suspect. Also, as you mentioned, those vessels have been intervened on multiple times. So I think the prognosis is very guarded, and then, of course, she's got end-stage renal disease. So I don't know. I mean, I think you've done everything you possibly can for the patient.
No.
And I think I'm impressed that the surgeon took the patient on with patent arteries and did a bilateral arterial graft, which was the right thing to do. And in someone with a porcelain aorta, I mean, that's gutsy surgery, and I'm very impressed. I would agree. I think I would have liked her to go to surgery earlier with a syntax score of 31.
And her prognosis depends on whether she finds a kidney donor.
Yeah,
I guess.
Marco, I was going to ask you on the mechanisms of all these complications. Would you think they were just stent malposition for all maybe the calcification she had? We only had 1 IVUS. And the second thing is that, do you have this experience with patients with, renal failure and end-stage renal failure?
Yeah, so I think with respect to the mechanism, the consideration I would like to put forward is the fact that you do IVUS does not mean that you are correctly interpreting IVUS. I mean, not that because you are pulling down the probe into the artery that the stenting procedure has been accomplished in a perfect manner. Of course, each of us is doing IVUS, but what we should discuss is how to interpret IVUS and how to translate IVUS into a better procedure. And for that respect, there is a huge room of discussion, of course. We have not seen IVUS, so unfortunately, I cannot judge stent apposition without seeing the intravascular imaging. That could be a potential explanation. But in a patient with CKD, instead of elucubrating and brainstorming about the stenting technique, really, I think the major mistake that I see in this case is really not giving the new P212 inhibitor, because we know that specifically in this patient population, platelet activity is extremely high, and clopidogrel can really fall very short in controlling that. And that would have been quite easy to do. And of course, in this setting, IVUS technique can tell you a lot. And if you don't interpret or if you don't do IVUS properly in the first case, even more importantly, you should do after the patient is back. Because you need to understand why the patient is having a stent thrombosis / wrist stenosis, or perhaps a combination of the two. And if you don't do it, of course, you cannot deliver the proper therapeutic approach. You should not keep implanting stent. And if the mechanism is really stent thrombosis, we have 2 independent registries showing that the mortality rate is much higher if you keep on implanting DES. I would like to know, though, what sort of DES has been implanted the first time, because that's not something I still see in my practice.
Integrity Resolute.
What?
Integrity Resolute.
I have seen 2 cases like this, and they were all based on first-generation DS. And actually, in one case, we had 4 stent thromboses on a row, despite we did whatever we could. We transferred the patient to the surgical facility, waiting for the 5th to happen. And when that happened, the patient has been transferred to the surgical theater and operated. But luckily, I've never seen that again after newer generation DS.
Dominic, can you comment on the using off-label new, like ticagrelor in these patients with end-stage renal function?
Yes, like everything that's off-label in that study, you use your clinical judgment, thinking what's best for the patient. And definitely, after the first case, I would have, with stents in left main, I would have gone with a newer generation. But I think the take-home message from this case is one thing that, as interventional cardiologists, we need to know when to stop. I think after the first or second restenosis, what should have been done, just get a TIMI-3 flow, suboptimal result with a balloon, put in a balloon pump, and send the patient to surgery.
Did you try to do that?
I have to say that we don't have cardiac surgery in our hospital, so it means that you have to transfer the patient with a balloon and intubate it for more than 100 kilometers. So it's possible, we've done it before, but surgeons are reluctant. The CCU in the admitting hospital sometimes is reluctant and doesn't have a free bed. So it's not that easy when you don't have the cardiac surgeons there to discuss the patient as we are doing now. So it's more by phone, but it's not the same. So, well, yeah, it would have been the best maybe, but we do what we did.
If I can, I would like to leverage on this comment, which I found very important. And unfortunately, I worked in the past in a place where surgical facility was not there, and I completely concur with you that surgical on site makes PCI people much better off. So I think that's a very important comment.
Any other comments from the panel? Yeah. Dr. De la Torre?
No, my only comment is that to put the main PCI in context, because this anecdotal case, unfortunately, is very, very rare. We have not seen something like this. And as you say, Marco, with new generation DS, we don't see thrombosis in lead main. In fact, in Syntax trial, 70% of lead main lesions were distal. And there was not interaction in the results, did not affect the good results of PCI with Taxus, which is not the best stent, in low and mid Syntax score patients. The meta-analysis also published recently of PCI versus CABG at 5 years did not show any difference in MI or death, and there was no interaction with distal location. And the second comment is regarding IVUS. Collaborative group in our working group in Spain for interventional cardiology has published this month in JACC Intervention the largest study in this issue. And we matched 500 patients with IVUS in the main PCI with DS and without IVUS. And in the distal, when there is the distal disease, and especially when you treat with 2 stents, there is a dramatic difference in thrombosis and restenosis using IVUS or not. This means that you have to use the best stent, you have to use the best technique, IVUS, and maybe the best antiplatelet therapy. But fortunately, this does not represent the PCI outcomes in lead main. This is completely anecdotal. And we are doing in Europe now 60% of lead main are vascularized by PCI, and it's growing because if you have a Syntax score that is low or mid, it's a very good solution for the patients.
Well, the this is not just left main disease. This is proximal LAD plus circumflex, two vessel disease.
I mean left main with low and mid symptoms. This is 31 symptoms, no?
Yeah.
31 is mid.
Yeah, but this particular group of patients in the syntax trial, you can count on two hands. It's very small groups, so it's hard to draw any.
Unfortunately, this group of patients were not randomized in the syntax study
No.
because the CKD was an exclusion criteria, so you cannot apply that evidence.
In the Excel trial, do you know how many distal left mains planned to be in that trial, or was it all comers? Because this is a very large trial of bypass surgery versus PCI for Excel. Do you know how many distal left mains?
60 something. Is that the percentage of distal?
Yeah.
I think it's 60, 62, 60 something % of distal in both trials.
Because I think that's an important definitive trial.
Yeah, unfortunately, as you well know, it has been stopped before reaching the planned sample size, and that was supposed to be a non-inferiority study, so unfortunately by study design and by premature discontinuation, no way the study will ever be definitive because it will be underpowered, whatever it will be shown, unless there is a huge difference in other arms.
I have a question, sorry, excuse me?
Yes.
I have a question for the surgeon, maybe mainly. I mean, it's quite interesting for me the fact that we can bypass with an arterial graft to an open vessel. And I wonder if you think that it would be a nice option in some many patients with a ventricular dysfunction, severe ventricular dysfunction in the acute setting, and then you treat a lesion to survive in the short term, but you are worried about the long-term survival. Do you think it could be an option for these patients?
I'm not sure whether I completely understood what you were saying, that you do a primary PCI for the acute situation and then a bypass?
No, it's mainly in a patient like we've seen the clinical picture, no? Patients with pneumonia, other comorbidities, and you are planning to postpone surgery, but maybe the clinical situation is not too good to wait for the surgery. What's your opinion on that?
You know, well, I don't know the answer either, but it is a very good point you're making, and we're going to have to rethink a lot of things. My colleague at the Mayo, Rajiv Gulati, published our data a month ago in Circulation on PCI and 5-year mortality. And what has happened, if you look over the last 25 years, the 5-year mortality used to be dominated by cardiac mortality. And then in the next decade, it was equal, cardiac and non-cardiac. In the last decade, the 5-year mortality is overwhelmingly due to non-cardiac disease. And this is really going to have to change the way we think, actually, because you know, we are reducing cardiac mortality, and the same applies to surgery. But it's on sicker patients who are going to die of other conditions. And I'm not quite sure how we're going to deal with that, but it is a factor. And I think that, you know, if you look at all the inclusion criteria for randomized trials, there's always a criterion there, no other life-threatening diseases for the next year. But I think it's a very difficult point.
Well, we also see that in valve disease, where we look at long-term outcome, that at least half of their mortality is not related to their valve disease.
Yeah.
Yeah.
Yeah, Dr. Sambola?
What do you think about the option of the use of stent dedicated to the bifurcation in this case? Because we didn't see the result about the first catheterization, and maybe the malposition is a problem in this case, a very important problem in this case.
Yeah, I think it's an excellent comment. Unfortunately, I am myself a little bit skeptical towards the current available technology. Every time there is a new dedicated bifurcated stent available, I always rush to try it, and I always decide not to use it in my clinical practice. And so I guess here the only real option is to perform a good stenting technique. And here we cannot judge it, because even from an angiographic standpoint, we have not seen whether final kissing balloon has been performed, we have not seen which sort of technique, bifurcation technique has been applied. So I think here the focus should be to optimize what is currently available instead of waiting for something to fall from the sky. I don't see a technology right now which is a breakthrough in this setting.
Okay, if you have no more questions from the audience, I'd like to thank you all. It's been a very good discussion for all these cases, and I think we close this session of clinical cases. And we have a 15 minutes relapse for our symposium.